And good evening to all of you joining us from around the world. Wherever you live, we welcome you to our live broadcast tonight. We are live 2 minutes ahead of our start time. That's going to give you time to get into the broadcast, get settled, perhaps get a glass of wine, relax, get your notepad out. You'll want to take notes. There's lots of learning within the next 60 minutes. And I would appreciate it. Look at that. 66 people already jumping on, and the numbers are climbing. As you watch and get settled, hello, I'm Carrie Dahl. I'm your MC and host for the evening. And we are going to have an interactive and packed 60 minutes ahead of us this evening. I want this to be informative and interactive for you. So go ahead and introduce yourself in the chat box. If you are just joining us, you need to grant StreamYard permission to use your name. Otherwise, you will show up within the broadcast as a Facebook user. Just say hello. Let me know where you're joining us from so that I can say hello back to you and you can join in on the conversation. But it's a little box at the top of the StreamYard broadcast technology that you want to grant StreamYard permission to use your name at the top of the comments on Facebook Live. Give them permission so that we can interact with you. And Dr. Guaneri and Dr. Tamari Height can also see your name when you pop up with your questions, because we do welcome your questions this evening and throughout the broadcast. Say hello. Don't be shy. We love the questions. We welcome them. So please go ahead and introduce yourself and let us know where you're joining us from. Like I said, we will be getting things underway in about 1 minute from now. There we go. It's starting to come in. Wow. Peter Cheng from Toronto, Canada. Welcome to you, Peter. Teresa joining us. Hello, Christine from CT. Is that Connecticut? Let me know. Not sure. Deborah Taylor, hello to you. Hello, Christina Fuller. My goodness. From Maryland. Hello. From Costa Rica, Doris Reg. Joining us from Toronto is Marcella. From Austin, Texas, Abby, welcome to you. Michael Knight from Park City, Utah. Oh, Teresa from Overland Park, from Rutherford, from New Jersey. Ian Ruckert from Carlsbad. Oh, wow, this is fantastic. Brenda joining us from Edmonton. Kim Lightfield from St. Petersburg, Florida. So many of you. It says Lila Fisher from Seattle. Bozeman joining us as well, an acupuncturist and functional medical practitioner. Madeline Cunningham, hello to you. Shipla from Pittsburgh. Sunny from London, Ontario. Lisa Torrey from Connecticut. From all over North America, I welcome each and every one of you joining so quickly, quite honestly. It's difficult to keep up with all the comments, but I will do my best to bring your questions into this conversation. We want this to be a conversation for you. We want you to leave this with some knowledge, some tools to get you thinking and learning about sleep apnea. So on that note, as you all get settled in, sign in and introduce yourselves. I want to say hello, doctors, dentists, researchers, scientists, and friends joining us from around the globe tonight. Hello and welcome to this live broadcast, The Science of Sleep Apnea, Clinical Perils and Innovative Treatment, our first in a series of live broadcasts. Tonight, we will feature two renowned experts, international lecturer, dentist, Dr. Tamari Height, and award-winning physician and researcher, cardiologist, Dr. Mimi Guaneri. Tonight, they will be discussing the science of sleep apnea from a medical physician perspective, as well as a dental perspective. My name is Carrie Dahl. I was a longtime television medical reporter and a 6 o'clock news anchor turned public speaking coach and podcast host. I am honored to serve as your MC for tonight's first virtual event. We appreciate the time all of you are taking out of your lives to spend with us this evening and learn more about the incredible work involved with diagnosing and reversing sleep apnea in countless patients, both young and young at heart. As I mentioned, we want this event to be as informative and as interactive as possible. So please, we encourage you to join in on the conversation. I will read your questions and your comments as they come in. I'm doing my best. We have a very large group on hand tonight. We appreciate every one of you. You do not need to wait until the end of the broadcast to ask your questions if there's something that you want to ask of either expert this evening. So all you have to do, as I mentioned, simply type your question in the comment box. Also make sure, as I've been saying, to grant StreamYard, which is the technology that we're using this evening, permission to use your name so I can read it out and include the name of the person in the question. It enriches our discussion, and who knows, Dr. Height and Dr. Guaneri may actually know who is actually the question. So if you choose not to include your name, that is fine as well. You will just show up as a Facebook user. The format for the next 60 minutes is simple. I will begin by interviewing dentist Dr. Mimi Height, who is based out of Edmonton, Alberta, Canada. She will talk about the treatment of sleep apnea from a dental perspective using the Vivos dental device. Following that interview, cardiologist Dr. Mimi Guaneri will join me from La Jolla, California, to talk about sleep apnea from a cardiology perspective. I will then bring back Dr. Height to join Dr. Guaneri to further the conversation. Area of discussion will include sleep disordered breathing and implications, clinical diagnosis of sleep disordered breathing in adults, and clinical pearls and innovative treatment options available from trained dentists. There is a lot to cover this evening, but research in this area, I can say it is changing lives, and you're going to hear more about that work and that research momentarily. As I mentioned, throughout the next hour, we welcome all of your questions. We're going to wrap up this evening at around 7 o'clock Mountain Standard Time. I also want you to keep in mind that if you do have to leave early this evening, or if you want to share this broadcast with someone who is unable to attend, a recorded version of this broadcast will be available on this website, www.thescienceofsleepapnea.com. So with that, let's dig in by welcoming Dr. Mimi Height, who has spent the last 25 years working in general and craniofacial dentistry and lecturing worldwide to dentists for the past 10 years, including orthodontists and medical doctors, on her published research and findings. Dr. Height, we are so thrilled to have you with us this evening.
Thanks, Carrie.
I want to begin here by saying this research, this area of study, it's truly become your passion. Why is that?
Well, I was a nurse for 10 years before I was a dentist. I worked in intensive care, cardiac and thoracic and plastic surgery and trauma. And I loved being a nurse, and I've been a dentist for 25 years. And I think I'm kind of a nurse dentist. So the thing I love about dentistry is I love everything about dentistry. I like doing things with my hands, but I have this freedom to practice using my professional judgment. And having worked with both dentists and medical doctors, I believe that every single medical doctor and every single dentist out there really loves their patients, and they want to really do the best by them. And we are a little bit different, but we all kind of took the same Hippocratic oath. And when you ask, why am I doing this? One of the things is you want to do no harm. And I started getting results in my clinic where I was actually reversing sleep apnea. And for me not to say anything would be doing harm. So all of a sudden, my general dental practice then is like I'm seeing sleep patients. I'm actually publishing papers. I'm lecturing, which started locally and went worldwide. And I'm sharing this as much as I can with my colleagues. And now it's come to this point where, some of the results I'm getting are being documented, and more dentists are doing it. And now we need to collaborate with medicine, because this is a systemic disease, and that's a medical doctor's realm.
Agreed, but let's point out what is really happening here. At the end of the day, you are changing lives and saving lives.
Yeah, it's just, dentists can do that. And I'm so excited to share that. Yeah.
And I also want to draw attention to the fact that you want to get this message out there as much as possible. You're in the middle of writing a book about this.
Yeah. Everybody knows we're not going to live past 150. So I just want to write down exactly what it is I'm doing. And I have so many people supporting me. I'm just standing on the shoulders of giants. So I'm going to do everything I can, and I'm having fun doing it. And I've met the most amazing people all over the place in dentistry and in medicine and in business.
And you did allude to the fact that this truly is a collaboration, bringing those two areas together. I want to dig in to the science of sleep apnea. And why don't we do that by, go ahead, Dr. Height, and give us a comprehensive overview of what sleep apnea is from a dental perspective.
Okay. So I'm a dentist saying sleep apnea is when you stop breathing at night. And I think medical doctors understand that. They're the ones that diagnose it. But all dentists are required to screen for sleep apnea, and it's no different than screening for cavities. So that's a requirement. And so once we start doing that, then we're so excited to help our patients. We're making these mandibular advancement devices, and those are really helping people with the treatment. But I'm going to show you a special device that is a mandibular advancement device just by showing you a patient. So we could go ahead and start. I'll just present my case, I guess. So the first patient here, I screened her for sleep apnea, and I sent her home with a level 3 sleep study, and it comes back with an AHI of 118. And I'm like, well, that can't be true. That's right. So much, but it's like 30 is severe, so I just called the doctor, and there the collaboration starts. So immediately they get her into the hospital, they do a level 1 sleep study, they get her on CPAP, and we can all breathe a sigh of relief. So what we did was, she had really big tonsils, and it took maybe 7 months before the medical community was really comfortable getting her under an anesthetic to take out the really enlarged tonsils. And after she healed from that, we did another sleep study, and she's still on CPAP this whole time. But, she still had an AHI of 70. And being a 28-year-old, she came to me and said, Dr. Height, I want your dental device to help with this. And I said, well, yeah, it's this dental device is cleared to treat mild to moderate sleep apnea, and you have severe sleep apnea. So you got to wear the CPAP, and then we can do the device at the same time. And so she said, yeah, I promise. And so this is the part that's really good. Just we treated her with this dental device and the protocol that goes with it. And after 9 months of treatment, if you can imagine, her AHI was 1. And so of course, in dentistry, we don't read sleep studies. We send them to the board certified sleep specialist. And then here's his report showing that, indeed, that this patient did not have sleep apnea with or without the dental appliance. So typically we'll do 2-night sleep study, one with the dental appliance to check, to make sure the jaw is being held forward enough and taking care of the sleep apnea. That's how dentists monitor the sleep. But what I wanted you to notice in her face, when I first presented this at the Academy of Sleep Medicine, many of the medical doctors were asking if she lost weight. And I hope you noticed that before and after treatment, her face was the same, and she did not lose weight. But what was really different was her teeth. And of course, that's what dentists look at, as the teeth. So if we go to the teeth again, you'll see there on the left, when she had an AHI of 118, her teeth look different than on the right. And so I usually, just tell patients and dentists, you can think about the teeth and the jaws like a garage and the tongue is like a car. So on the left, her upper teeth overlap her lower teeth by about 50%. So she's got a garage with a 5-foot ceiling, and the bottom jaw is way far back. So that garage is made for a smart car. So when she
Tamari, Meredith Broderick says, how many millimeters is that?
So yeah, a 5-foot ceiling. Well, I'm trying to draw an analogy between a garage and a car. So if we think of the teeth and the jaws like a garage and the tongue as a car, that's you can imagine that the tongue is really backed up far into the airway. And dentists are trained so much. That's such a great question, because dentists just think of the teeth and the jaws, and they lots of times we have to learn to think past that, where the tongue is actually going back in the airway. So now after the treatment, her bottom jaw has come forward, and now she's got a garage for a stretch limo and a 10-foot ceiling. So the tongue has now come out of the airway, which lies behind the jaws. So I really appreciate that question. And now if we look at her from the front, you can see that before treatment, she had a 1-car garage because all her teeth are kind of tipped in and things like that. And then after treatment, when her sleep apnea was gone, she's got a 2-car garage there and even has some gaps in her teeth. Now, this will drive dentists nuts because all they see is gaps and that the teeth don't fit together. But we have to look at this like it's phase 1. And phase 1 is to get the patient healthy, get rid of the sleep apnea, get rid of the pain. And then this is where the orthodontists come in, and many dentists do this too. We can line up the white things, line up the teeth so they all fit together and support that nice garage. Now, another thing that can impact this is the car, which is the tongue. So when a person gains weight, their tongue gains weight. And conversely, when they lose weight, the tongue loses weight and it gets smaller. Another reason a tongue can be enlarged is if it's tied. So if the tongue is tied and it doesn't have full freedom and full function, the muscles in the back of the tongue get really big and the tongue itself becomes an obstruction. And as well, it doesn't grow the maxilla. So let me show you a little bit more about what's actually happening. What we did before and after treatment with this patient, and by the way, this patient was sent to me by Dr. Kim Bolt from Edmonton, and she's on this call. Hi, Kim. Anyways, what we're doing is we're correcting these craniofacial developmental deficiencies. And what we did was we actually, get ready for this, we grew the bone volume of the upper jaw. That's the maxilla. We grew the bone volume of the entire maxilla by 1.8 cubic centimeters. So if you imagine the volume of 2 dice, that's how much we grew that bone non-surgically. And if you grow that bone and improve its symmetry, you'll see that the nasal airway is located in that bone. The nasal airway also grew by over 2 cubic centimeters. And so sleep apnea starts in many cases with an upper airway resistance, and you've just relieved that. Then what happens when that entire upper bone grows? Now there's room to fit the teeth. So dentists like it because they can straighten the crooked teeth. And then what happens is that bottom jaw comes forward. Like, we can move our bottom jaw all over the place. If the landing pad for the bottom jaw is now big and the teeth are all spread out, the bottom jaw can come forward and this teeth can fit in there. And guess what happens next? The airway opens in the neck. So what we're looking at here is better anatomy. So what we can expect is better physiology, and we can measure that by doing sleep studies to see if the sleep is better. And if we take it one step further, we can think about REM sleep. And I got these images from Dr. Matt Walker's book called Why We Sleep. I love that book because it's easy to understand. And that's what a dentist needs. That's what I need. But anyway, we can then measure and see how does that affect REM sleep. And in addition, we could look at the sleep architecture. And, this is where all the research can be coming now. We've got so much data on this. How does this affect sleep architecture? And then we can even take it a step further and we can go, okay, so So what about, adenosine? What about the sleep drive and the wake drive? How can we kind of optimize the human? So what we're doing here is we're actually changing the phenotype non-surgically and without drugs to optimize the genetic potential of that patient. And the genetic potential of the jaws is to have 32 fully erupted teeth. That is including the wisdom teeth with no crowding and supporting a normal airway. So that's what's really exciting. We were taught in dental school that you couldn't grow the maxilla, and there's nothing wrong with that, but that was a null hypothesis, which has now been disproven. And a lot of work in dentistry is done with the belief that we cannot change the bone volume of the maxilla non-surgically. So Kim Bolt just texted in. Does everybody see that?
The patient's medical doctor phoned me and thanked us for saving her life. There you go.
Well, I think this patient is saving a world of lives, because I'm doing this every single day in my clinic. As a dentist, I'm 100% airway now, and I had to get an associate to do my other stuff. All the dentists need to get together and be on board and know that, you're capable of doing this, because it's not hard. So
Dr. Height, how common is sleep apnea in your practice compared to just how prevalent it might be?
Well, it's strikingly, it's more common than you might think. You can't tell by looking at a person that they have sleep apnea. A lot of them think they're overweight and things. And I just want to let me address that in a sec, because I want to show you, here's the data that shows we grew the nasal airway volume. And then the slide before that shows how we grew the maxillary bone volume. And so this was the reason I'm showing you this is a small group of patients, but this was like a few years ago. But what's really cool is Vivos Therapeutics has this airway intelligence service, which is now using these protocols, and they have over 12,000 patients in treatment now. So we can really do some research, and I really think this is an opportunity for every single sleep society, every group that, dentists are really grabbing onto sleep apnea and learning about it, but everybody can pool their resources. It's really exciting, and learn about sleep apnea. But it's very, very prevalent in the practice. A dentist's whole practice is full of patients that would want this treatment if they knew they could have it, and if they knew how to look for it. And even skinny people can have sleep apnea. So
a great question I wanted to bring in at this point from Sanjay. During this process, does the patient have trouble chewing?
Do you know what's interesting? I don't get that as a big complaint. As the upper jaw is changing in shape, the protocols for this process is more about creating space and letting Mother Nature do the healing. And so many people have less pain and less chew. It's easier to chew. The concerns or the sort of side effects are aesthetic, the gaps in the teeth, but we all know there's phase 2. And if a patient doesn't like the gaps, then they can get that. Another one is while they have the device in their mouth, they lisp, or they could salivate more or have a dry mouth. So the side effects are very low compared to the benefits. But it's very fun doing this treatment.
How about this question? Desiree Stewart says, very interesting. Do you think it can be recognized sooner in a dental office than a doctor offers?
Well, you know what? That's a really great question, because what dentists, I think, see the most healthy people of any healthcare provider. Everybody goes to get their teeth cleaned and checked. So dentists really have an opportunity to screen. We're required to screen. They have an opportunity to screen every patient. And then, those patients can get a sleep study, whether it's from that dentist or from the medical doctor. And if the medical doctors would work together with the patients, we could rifle these people through, get their diagnosis, give them their options, and let them get treatment. But typically patients will have nice aesthetics after this too, because the symmetry in their face improves. And you can see here that, not only can we measure the bone volume and the nasal airway volume using the amazing cone beam CT technology we have at our fingertips now, but you can take photos and we can see the functional space improve and the symmetry. So there's lots of ways to measure a result in these patients, but the biggest thing is these patients just feel better, and they say things like, I can breathe through my nose for the first time in my life. Another way dentists can really measure the progress of their patient is with a headache impact test. And if you just Google HIT6, you'll get this test and just read how to do the results. But in a nutshell, when I'm treating patients with their overall headaches, it's how their headaches impact their life. The scores come down, and lots of patients are headache free after this. And then, yes.
Go ahead, finish your question. And then I want to get to this question here that says, does a dental appliance cause issues with bite and due to the movement of teeth due to dental caps and inlays?
That's a great question. No more than any other orthodontic or dental treatment. It's not a concern with the patients. Everybody knows beforehand that they might need ortho after. Now, just to tell you, lots of patients actually finish this treatment and don't require ortho, because if you imagine the upper jawbone changing 3D and say the teeth just stay lined up, most of the changes coming in the actual jawbone. But I tell all my patients beforehand that they have to prepare themselves for orthodontics if they don't like the aesthetics or if the bite is off.
Another great question. What questions are you asking your adult patients to screen for sleep disordered breathing?
Well, hi, Sylvie. I've actually developed a process, and this is where Vivos has been great. They've got a lot of experience with practice management. They're taking dentists who are running busy dental practices, and they're teaching the entire team how to do this so that the dentist doesn't have to teach them. So it's fantastic. The entire office becomes an integrated practice, and all the work is done by your team. So it's all in your admission sheets, and then you spend the time with the patient getting a history, doing an exam, write down your diagnostic statements, give your patient a letter at the end, and kind of the dentist's job is to diagnose and design the device and adjust it, and the team does everything else. And the team just loves this. Man, some of the results, they love coming to work, and they take care of that, and everybody learns how to look for it. So you don't even have to advertise for this. Your entire practice is full of these patients, and everybody brings in their family first, including the medical doctors who are getting a letter from the dentist, and they see the results in their patients, and then the medical doctors will come.
Dr. Haidt, I know you have so much information to get to, but these questions are coming in fast and furious, and I want to address a few more. Here's one from Darren and Anita. Can a PT with history of TMJD use this advice?
Absolutely, yes. That patient I showed you with the nasal symmetry there, he was a TMJ disorder patient, and he had half of his condyles missing, and he was a farmer, and he was busy. And for him to come in to my clinic in the middle of harvest means he's in some wicked pain. He was told by the surgeon there's nothing he could do but live with it. Initially, I used a neuromuscular orthotic on him, and I love neuromuscular, and you get really great results with it. And many dentists get results using their splints too. But it was the Vivos device that completely cleaned up his pain, which he didn't care about anything else. He didn't care about aesthetics or anything else. But we took all those photos, and he was a pretty guy after. He was symmetrical, and his pain was gone. So it's very supportive of the jaw joints. But I'm going to finish through what I have to say, because I'm excited for you guys to hear about Mimi too. So the other point I want to make here, and this is the important, very important to show, that this actually, in my practice, has reversed sleep apnea in patients significantly. So the first block of stack of blocks you see there is before treatment with the Vivos device. And you can see in dark blue, those are people with severe sleep apnea. And then the lighter the blue, the less severe sleep apnea. So everybody had sleep apnea before treatment. And then after treatment, with an average treatment time of 18 months, the very, very light blue are people that are quote unquote normal, or they don't have sleep apnea anymore. And you can see how much lower the severe is. And, a lot of those turned into moderate and then mild. And, everybody, this was a snapshot in time. Some people were still in treatment, some stopped treatment for whatever reason. But basically, the results we're getting from this are 80% of the patients will improve by 50%. And in medicine, here are the top 10 drugs that are used to treat pain in people. So back to the TMJ question, the headaches. The people you see in red there are all the people where these drugs don't help, and the people in blue are the people that these drugs do help. So the best they can do in medicine is 25%. And in this snapshot in time, we have 80% of the patients getting better by 50%. And that was just, tested. They tested out 7 or 8 dentists and about 75 patients to get this data. But as I said before, Vivos Therapeutics now has an airway intelligence service with over 12,000 patients in. We're gathering all this data, and they can teach your entire team how to do it. And it's not this big panic. Like, you can just continue doing the dentistry you love to do, and maybe do 1 day a month or 1 day a week, or you can be like me and just do it full time.
I know, Dr. Height, there's so much information that you would love to get through, but we will bring you back. And this is one I want to perhaps tackle with Dr. Guaneri. It is a great question, because she says we're having difficulty with getting sleep studies being read by a sleep doctor, but still just proceeding with Vivos appliances. And that speaks to the overall issue that we're talking about tonight, about the two areas of medicine collaborating. And I want you and Dr. Guaneri to tackle that after we hear from her. So, and any other bits of information, we have some time at the end. Any closing thoughts before I bring in Dr. Guaneri?
Yeah, I just, this may be a crazy thing to say, but I feel like dentists are kind of like, my presentation has lots of pictures and things in it. And we like to tinker, and we're kind of like these, biologic, mechanical engineers type people. And medical doctors, they just hang their hats on the research and the clinical trials and the peer-reviewed journals, and they don't even read our journals. Why would they? And it's like two different things. They're almost like chemical engineers, like organic, that kind of thing. And I think we both have our own styles. And then if we somehow really understand how each other think, that's how we're going to collaborate. And medical doctors will want to diagnose this, and dentists will want to treat it. And there will be a lot of patients who want this treatment.
Amen.
And governments will want to help, because Dr. Guaneri is going to show you how much money can be saved for governing bodies.
Oh my goodness. So much information there. The questions just keep getting better and better. But Dr. Height, I am going to go ahead and put you into the virtual green room for you to relax and catch your breath there for a minute before I introduce Dr. Guaneri. This is important. I want to draw attention to this because the question came up, and this is from Brenda, who's well connected here. She said, call me. I work for Vivos, and I can help you with where to get your studies read. 780-717-0759. So that's important information to note as well. And I wanted to bring that to the forefront. Okay, what a discussion we're having. I'm seeing your questions, I promise, but there's so many coming in, and we will do our best to address as many as we possibly can. But we need to move forward in our broadcast, and it's now my pleasure to welcome Dr. Mimi Guaneri from California, a nationally recognized cardiologist who has been interviewed on nationally syndicated television shows, including the Dr. Oz Show, NBC Today, PBS Full Focus, and To the Contrary. contrary. Her work also was featured in a 2-part PBS documentary, The New Medicine. Dr. Guaneri is the founder and president of the Academy of Integrative Health and Medicine. Without further ado, Dr. Guaneri, what a pleasure it is to have you with us tonight, joining us from beautiful La Jolla, California. Is it a great night there?
It's a great night. The sun is getting ready to set soon, and it's a beautiful day.
Well, we're having quite a discussion here, and I know that you want to weigh into this. And I guess the burning question that I would want to know, looking from the outside in, is why would a cardiologist be interested in sleep apnea?
Well, it's a great question, but I have to say, every patient I see, I end up screening just about for sleep disordered breathing. Why? Because we know without a shadow of a doubt, and we can go to the next slide, I put up some numbers for everyone. The cardiologists out there know this. It's so prevalent amongst people with cardiovascular disease. And we know, for example, that obstructive sleep apnea is a cause of hypertension, a cause of increased risk and incidence of stroke, heart failure, atrial fibrillation, just about everything we see every day in our practice. And the really sad part about this is it's modifiable, as you just heard. You know, in cardiology, we talk about lowering cholesterol and getting blood pressure under control. Well, let's get sleep disordered breathing under control, and we can make major headway here.
Agreed. So cardiologists, and you just use the term hypertension, you always have related that or called that the silent killer. So is there a link between sleep apnea and hypertension?
No doubt about it. If you take just a simple schematic from a great article that appeared in the Journal of the American College of Cardiology, what we're seeing now is more and more people, of course, with obesity across North America and across the globe. But as you just heard from Dr. Haidt, you don't have to be obese to have sleep apnea. You can have instability of your respiratory control, like in central sleep apnea or upper airway dysfunction, which is something we see with obstructive sleep apnea. But when you start to pare it down, and for the cardiologists in the audience, you know this, all we talk about in cardiology is inflammation and oxidative stress, decrease in heart rate variability, increase in sympathetic overload. All of these things occur in the setting of sleep apnea, and the end result is heart disease, endothelial dysfunction, hypertension, and arrhythmia. And I have to say, increased mortality. So I encourage not only cardiologists, but family practice docs, internal medicine docs, anyone who sees a patient really should be thinking about this.
So then on that note, the dental device that Dr. Haidt was alluding to throughout her presentation, what impact would that have in a cardiologist practice like yours?
Well, it's going to have a huge impact. So, for example, we know if we treat obstructive sleep apnea, not only do we save money, which is what Dr. Haidt mentioned earlier, but take a look at the mortality data. We improve mortality. And at the end of the day, you just saw a young woman with sleep disordered breathing and her primary care physician saying, hey, you saved her life. So if we think about the cost of healthcare and the causes of cardiovascular disease, whether it's AFib, heart failure, arrhythmias of other types like ventricular tachycardia, etc., it's all related to sleep disordered breathing. So if we can at least put this into our list of modifiable risk factors, right there with cholesterol and diabetes, it's a home run. And if we have a device that enhances compliance, like the Vivos device, for example, that was just shown, my patients always say to me, I don't want to travel with a machine. I don't want a machine every night. I don't like the pressure on my face. I hear every possible excuse. So that's why I'm so excited about this.
Before I move on to the next question, I want to bring in Amna's question. She says, below what O2 saturation causes these physiological effects, and how long does that desaturation need to last?
Right. So even short periods of desaturation can cause arousals and sympathetic wakenings, right? So blood pressure goes up, heart rate goes up. We need to keep the O2 saturation at least above 92. So if you were to draw an arterial blood gas and you looked at the O2 sat and you said, wow, the O2 sat is 92, I will tell you the arterial blood gas is about 65. So you don't have a lot of margin there. Once you get below 90, okay, you are starting to affect cognitive function, heart function, and so on.
Okay. Main challenges, Dr. Guaneri, of a sleep apnea diagnosis in your medical specialty?
Well, I think we're just not screening enough. Most people are completely missed. In my specialty, I see all sorts of things. Here's a simple example. I screen people using multiple different kinds of devices in my office. This is a gentleman who came in for cognitive decline. And I don't know if it's too small for people to see, but to the left, if you look at oxygen saturation, 133 minutes, this gentleman's oxygen saturation was below 90%. All right. And that's just, you don't have oxygen to the brain, you don't have oxygen to the heart. And of course, this person did not come to me for sleep apnea. They came with a very different complaint. So screening today is very easy, and we have devices which should be used, should be in every office, where someone can take home a device and screen a patient very easily. This is a 56-year-old mathematician, brilliant woman who was recently diagnosed with dementia, and her husband brought her in to see me, knowing that my cardiovascular practice, I have an integrative approach and do things a little differently. And as you can see here, a similar situation with oxygen below 90 most of the night. And this is the reason for this woman's cognitive decline. And she would be a perfect candidate for Dr. Haidt, because while we may start with a CPAP in her, CPAP in a dental device, ultimately to correct, she had structural abnormalities from Marfan syndrome, would be absolutely perfect.
And you have one more example, a 14-year-old girl.
Right. Here's a child who's been having seizures, 9 seizures a night. Again, mom came, and I don't usually see children. I'm an adult cardiologist, but clearly no one screened this child for sleep disordered breathing. And as you can see, her apnea hypoxia index is fairly high. And again, we see oxygen saturations that are significant. So if you go into any family practice, internal medicine, cardiovascular practice, we should be doing this routinely. We are missing most of these patients, and especially patients with atrial fibrillation, congestive heart failure. We're just missing all of them, and it's an important piece to the puzzle.
So how will the use of this device then impact your work and that of your patients?
I think it gives us options that we currently have not had up to this point. We have been limited by treatment options because of poor patient acceptance, poor patient compliance, for the reasons I mentioned earlier. And furthermore, lack of diagnosis has been rampant in this condition. And now with the nighttime sleep studies that people can take home, there's no longer an excuse for that. And having the opportunity to screen people and then work. I just love this concept. In integrative functional medicine, we talk about interprofessionals working together, to have the dentist, the cardiologist, the sleep specialist, all of us coming together with one goal in mind, which is to restore health. And we can really save lives here, and we can really help people to feel a lot better.
With that, a nice question here from Sylvie. Any experience with patients with Parkinson's?
I think if they have evidence of sleep disordered breathing, we should treat it. We have different protocols for Parkinson's, but certainly we screen people who come in with Parkinson's for sleep disordered breathing. And if they have that, then by all means, we need to treat them.
Another great question, and I know you can't diagnose, but it just makes for good discussion here from Kim Lightfield. She said, I had a grand mal seizure last Tuesday, first time. Oxygen level went below 70% during the night. I will be taking a sleep apnea test soon. Could this have caused the seizure?
And we just discussed that with the 14-year-old girl, Kim. Absolutely get that test sooner rather than later. And also, I just have to say this because I'm an integrative clinician. please make sure you don't have a gluten sensitivity, because we see that first seizures related to gluten sensitivity as well.
From Aragon Asleep, what do you say to a cardiologist if they take a traditional approach to their specialty and doesn't want to screen their patient population and want their primary care to address this?
I think every cardiologist should really want to be doing preventive cardiology, just like we give statin therapy to lower cholesterol or blood pressure pills to lower blood pressure. Why are we not screening for sleep disordered breathing? It just doesn't make any sense at all. And to me, if the cardiologist doesn't want to do it, then send them to a sleep specialist or go ahead, primary care. You could do this. This is within the realm of your specialty.
Dr. Guaneri, what about other options available? There's a comment here from Raul saying, Dr. G, any comments on a system called Inspire? And from Ina saying, does Scripps have a sleep apnea clinic for diagnosis, and do you use them? Meredith also saying, love the Watch Pat 1 device. Your thoughts on other options available?
Well, first of all, hi, Raul. That's actually one of my patients, and I'm thrilled that my patients are on this webinar. I think it's just great. Yes, of course. I think you have to individualize the treatment. What is causing the apnea? Like Dr. Haidt just showed, big car, small garage. If we can open that space up, you don't need the Inspire device. Someone else who may have a neuromuscular problem may need an Inspire device. So it really is individualized. And I want to say I love the WatchPat 1 device, and I do think there are excellent Scripps clinicians that do sleep medicine. We have very good clinicians in San Diego, Del Mar, and all of Southern California.
Dr. Guaneri, this has been so insightful to hear your perspective on this issue. At this time now, I want to make this an inclusive discussion and bring Dr. Haidt back into this. So we have cardiology meets the dentistry, the three of us together here, most importantly, the two of you. And I know that you talk often, but I'm going to just pass the baton to the two of you and ask you if either one of you has questions of the other for those that are watching.
Well, should I go first? Because I have a question for you, Mimi.
Oh, go for it. Go for it.
So, healthcare practitioners need to kind of want to do this. And I know we all want to help our patients, but we really do love what we're doing. Like, I know some dentists that just love implants and they don't want to do anything else but implants. And I think that made me think of that when somebody asked about the cardiologist not wanting to screen for sleep. So even if a person loves doing implants, they need to know how to look for cavities. And now it's required that we screen for sleep. So they can get their front end to do it or whatever else. But does your governing body have a requirement if someone is practicing a certain way on that where they have to do it, or can a person just choose not to do it and not do it? Like, what would make a medical doctor want to do this?
Well, I think we have to look at someone is coming to you for healing and someone coming to you for help. Just like you would say, pick up a blood pressure cuff and check a blood pressure. Right? I think it's a matter of education. And that's why I love the fact that we're doing this, because I know tomorrow morning, everyone who walks into their clinic is going to be looking for sleep disordered breathing. And they're going to be asking the questions about snoring and waking up at night. And they're going to think, oh, my patient has high blood pressure. Should I think about sleep disordered breathing? AFib? Should I think about sleep disordered breathing? So I think it's just a new wake-up call for more education. I don't think it's more than that.
So is the best place for a medical doctor to get that at the Academy of Sleep Medicine, to get more information and more training if they want it? Is that kind of the go-to spot?
Well, of course, you can go to the academy. You can get certified in sleep medicine. That's for certain. But even your internal medicine training. I'm an internist as well as a cardiologist. Every 10 years, I take an exam, and the pulmonary part of my exam is all there's a lot of questions about sleep disordered breathing. So it is considered part of our practice. And if anyone does a review of systems where you go through all these questions for patients, you should be able to spot this very quickly. I think what I missed for years is where you come in. I always thought for years that the sleep apnea person was the, heavy set, short neck, right? And then I started to realize, no, wait, it's the big tongue and the big tonsils and the backset jaw and the facial deformities. As a medical doctor, I was never taught any of that.
Yeah, and I think dentists really, like, I feel like sleep apnea is a disease of the craniofacial anatomy, and we have the ability in dentistry to manipulate or to move that anatomy or allow it to optimize. So that's where I really love what we're doing too. And my hope is that we can figure out a way, for the diagnosis to happen, because I know the sleep studies need to be read by a board certified sleep specialist. And Dr. Clay Kishida is going to come on in the next webinar and help us with, okay, we have so few board certified sleep specialists. How are we going to get all these billions of sleep studies read? And how are we going to get everybody educated? Like, I think Vivos Therapeutics, they've got the engine rolling. I think that's a good place for dentists to learn. I think it's sitting there for medicine, and now we just got to do it together.
So if you do it together, let's talk about the potential impact. If dentists and doctors are truly collaborating, what could be the potential outcome here?
I think we're going to save a lot of lives, and I think we're going to save a lot of money.
And a lot of money.
A lot of money, and we're going to help people come down on their medications. Maybe not everybody gets off, but they're certainly going to come down. And more importantly than anything, quality of life, right? And if, you didn't say it so much, Tamarie, but when I look at those photos that you showed, I mean, you were really showing a fix. You were showing a cure. I mean, I know we don't like to say those words lightly, but when I see no device and I see AHIO1, I can't help but say, let's do, many, many more of these because we have repositioned this person's anatomy. And if I was a dentist, which I am not, I would be jumping for joy right now to be able to be part of this. And if I'm a cardiologist, which I am, and I know I have some colleagues out there of all types of colleagues, I know everybody's going to be thinking differently about screening.
Ladies, can we take some questions here? Here's a good one. It's from Sanjive. Is there a precursor on ECG or Halter to atrial fibrillation that alerts you to the possibility of underlying SDB?
Yeah, that's a great question. You may see, the first thing you may actually see is a reduction in heart rate variability. Sleep disordered breathing is associated with changes in the beat to beat heart rate response. So that's the first thing you would see. But usually most people will come in with atrial fibrillation. And unfortunately, by the time I see them, they've seen 2 or 3 other cardiologists. They've had an ablation for their atrial fibrillation. I remember seeing a gentleman who had had 2 ablations. And when I tested him for sleep disordered breathing, severe sleep disordered breathing. And when I called the cardiologist said to me, oh, sometimes it's the simple things in life. And I thought, well, let's fix the simple things in life. So heart rate variability may be the first change you see, but certainly atrial fibrillation should alert you to possible sleep disordered breathing. Hypertension should alert you. Congestive heart failure should alert you. All of these things that we see, pulmonary hypertension should alert you. These are all red flags for sleep disorder. And one that we didn't talk about, very big one, is depression. Depression about in cardiology. We know that sleep disordered breathing causes something called cytokine sickness. And that cytokine sickness is linked to depression. And for all you docs and healthcare providers out there that are non-dentists and see a lot of depressed people, how many of them had sleep apnea and we missed it? And so that's an important one.
Well, one of the tests I do before and after treatment on the patients in the dental clinic is a Beck's depression survey.
Yeah.
So we're getting all this data, and it's very exciting for, I think, every medical doctor, every dentist, every university, graduate programs. This is a hotbed for research, and governments are going to love this because, like you said before, we're going to save billions of dollars if we can get people just healthier and get their anatomy more normal.
Yes. And the numbers are what? 1 in 4 people battle sleep apnea. Is that correct?
Most of them are misdiagnosed or not diagnosed, right? We say 17% to 35%, 40% lucky if we get it right, that are actually diagnosed. So I think really we don't have those numbers right. Okay. And I'd like to just add that for the docs and the dentists that are screening people, think about the unusual. Have you ever had a motor vehicle accident? Most head-on collisions are related to sleep disordered breathing. How are you doing at work? Are you on disability? I mean, all of these things can be the result of sleep disordered breathing.
This question has come up 2 or 3 times. Dr. Haidt, it says, is there any concerns promoting bone growth, possibly promoting bone tumors?
That's a great question. It's interesting. What we're doing is allowing the body to express its genetic potential. So distraction osteogenesis, 3D, we're turning on the stem cells, and we're not causing inflammation. It's more of stimulation and creating space for the bone, the maxilla, to change. So if anything, what happens as a result of that, getting a deeper sleep, and you could, I don't know, read Matt Walker's book. I thought it was good. But like if a person gets a nice deep sleep at night, they kind of heal themselves and they fight these cancers. There's a connection between having REM sleep and disease like cancer. So I actually think it does the opposite. It grows the bone more normally, and probably, and again, here's an area for research. There's a research question. When you can reverse sleep apnea, it creates more questions, but they're better questions to spend our time. And the more questions you answer, the more questions you have. And
I want to squeeze this one in. Dr. Haidt, can you recommend CE courses for dentists to learn more about sleep apnea?
Oh, heck yeah. Just make your life easy and just go to vivoslife.com. And as a dentist, you can just stay in your lane. You don't have to manage your practice. I mean, I did, but like, you don't have to do those things unless you want to. If you love doing just dentistry and you just want to learn how to diagnose and adjust this thing, your team does all the rest. And this company is fantastic. I mean, they've figured out how to take a dental office and just make it happen for you so that it's not this huge stress. So that to me is the most efficient way right now. But I would encourage all societies to keep working on what they're doing, and just keep exploring and finding better ways to help diagnose this and help treat it collaboratively with medicine. Because I think as a whole group of dentists, we need to get together and pool our resources and work with medicine together. And that's how we're going to get through the billions of people that have this worldwide. Like it's a really great time to be a dentist and a medical doctor right now. So this is good.
Dr. Guaneri, any final thoughts before we close out the broadcast?
Well, I just want to remind everyone that we really need to do this together. And as Dr. Haidt has said, this is that one area where we can really build a bridge. And Western medicine for conventional people like myself forgot about the mouth. I mean, we just weren't trained in that arena. And I would encourage even the medical doctors to go to the Vivos site and take a look and poke around some of the literature and see what's there. And to just remember in the morning to skip screening.
And Dr. Haidt, final comments from you.
Yeah, this is the breathing wellness movement and the craniofacial wellness. And I think medical doctors don't have to worry about the teeth and the jaws. We can help. And we would love to have referrals from you. And, if you go to the site and you don't find a Vivos doctor there, then go to your own dentist and play the webinar for them, or just get them to start practicing this way, and we'll get it going everywhere. Those dentists will become leaders. You need to lead this breathing wellness movement.
A couple of final questions and comments coming in from Virginia. Such a terrific discussion. Thank you for the range of topics. From Linda, she says, what is the name of your book, Dr. Height? Thank you for the presentation.
Medical dental collaboration to eliminate obstructive sleep apnea. Can you believe how bold that is?
I love it. I love that you are going there. Dr. Robert Bruce says, wonderful discussions tonight. Thank you very much. There is this looming question. I brought it up earlier. We didn't get to it. What's the cost involved? Can you wrap that up in like 20 seconds or less and give us a ballpark?
Well, it's estimated about $10,000 for a year of treatment. If healthcare pays for it, it'll save a bunch of money in other areas, so it's not that expensive compared to other treatments. But again, it depends on the individual, and the take home is the earlier you get treatment, the less treatment you'll need. So you want to start your patient when they're 1 day old, and we'll have a follow-up webinar on pediatrics, which is prevention.
Yes, looking forward to that. Kelly Naren Rice says, I'm a Vivos provider. I'm so excited about the future of continuing to work with physicians to help more patients. Thank you for spreading the word. And the final word tonight goes to the one and only Clay Kishida, who says, great presentations. Speaking of Cleat, well, we're going to get to him in one moment, Dr. Kishida, but I want to wrap up now as we watch our time, and to thank the amazing Dr. Mimi Guaneri joining us from La Jolla, California tonight, Dr. Tamari Height for her insight and wonderful discussion, tackling all sorts of information and issues and your questions. And to those of you joining us really from all around the globe, thank you for sharing your precious time with us this evening. As I mentioned at the beginning of this broadcast, if you want to send this broadcast to anyone, just go to this website, www.thescienceofsleepapnea.com. I'm going to put that up on your screen right now so that you can write that down and make note of that. And as I mentioned before we wrap up the discussion, it's the first installment of a larger series of broadcasts that will feature discussions from a variety of doctors in different areas of medicine. If you're interested in following along, well, our next live broadcast will take place on Thursday, March the 25th, once again at 6 p.m. Mountain Standard Time, featuring Dr. Clay Kishida. I know many of you know his name and his amazing work. Dr. Kishida is an academic physician scientist whose major accomplishments and roles include serving as inaugural president of the World Sleep Society, the World Sleep Federation, and the American Academy of Sleep Medicine. He's conducted clinical research since 1977, authored over 250 publications and 6 books, and is the past recipient of the highest professional awards in the field of sleep medicine. Mark your calendars, Thursday, March the 25th. Save that date, a discussion with Dr. Tamari Height and Dr. Clay Kishida. On behalf of all of you joining us tonight, Dr. Mimi Guaneri, I want to thank you for the brilliance you brought to this discussion. Dr. Tamari Height, thank you for blazing a trail in the treatment of sleep apnea. I'm going to continue to follow both of you to see where you take this and the impact that this has with the days and the months and the weeks ahead. Bottom line, you are changing and saving lives. To all of you who joined in tonight, thank you so much for your time. I hope to see you back here in 2 weeks. Good night, everybody.
Night.
Good night.